Good evening, guys. Thanks for joining us. Yeah, sorry about the little delay there. I mean, a technical issue. We've got it all sorted now. So yeah, big thank you to Caltech and Mar for sorting these webinars out. They're very good, and we're enjoying them, aren't we, Abid?
Fantastic. Loads of fun.
Right. So yeah, so this is Abid. You probably saw him from last week. Went over the big toe. This week we're going to look at the supraspinatus and infraspinatus. Okay, my name's Adrian Burman. I've been a sonographer now for 13, 14 years, I guess. Started off as a radiographer and progressed through into ultrasound and specialised in MSK after that. Okay, so the first thing to do when we look at the shoulder is to get the right position. So I'm going to go through that first. There's two different positions for the shoulder. It's specifically to look at the supraspinatus. Now, one of them is called the crass view, and the other one's the modified crass. So the first one, the crass view, is with if Abid can put his arm behind your back. Okay, so those that can't see that, so what Abid's got here is his arm behind his back. Okay. And that brings the supraspinatus, which is hiding underneath the clavicle, down and forward, so we can image it. Because if you don't do that, it hides under the clavicle and you won't see it. Now, the modified crass, which is the one I use, is a slight alteration because in this position that he's got, it slightly internally rotates the shoulder, allowing the biceps just to hide away a little bit. Now, the modified crass is a slight change. So what we do is we put the hand on the back as if he's going into his back pocket. Okay, and that just brings this biceps tendon, which we use as a landmark, just to help see that supraspinatus a little bit better. So, first thing I'm going to do, I'm going to be looking at the supraspinatus, obviously, because that's what this talks about. But I'm going to start on the ACJ, which is the acromioclavicular joint. And the first thing I do is from the ACJ, I go directly down with Abid in that position, and then that will give me the first point of call for the supraspinatus. Okay, so now I'm going to adjust the screen a little bit here. So we're on the 17 megahertz probe, which is the highest frequency. And if you look on the screen to the right, there's a little red triangle. Okay, now that's your focus. That's where your image is optimized. So I want to move that down a little bit. So I'll get the pointer out there. So this is what I'm talking about here. This little red thing here, that's your focus. And this is the supraspinatus. So here we've got the skin, we've got the deltoid muscle. And actually what I can do is I'll freeze this. Oh, sorry, Abid, you're right.
Yeah, I'm just trying to adjust.
So if I freeze that, then I'm just going to quickly annotate this. So this will be the deltoid. This is the supraspinatus. Now, I'm a little bit off here, so let me just go back. So there's the biceps tendon. So deltoid, just let me know, Abid, if you're struggling with that position.
Thank you.
Supraspinatus there. This is your humeral head, and this here is your biceps tendon. So that's this is your landmark picture first of all. Okay. Now, I need to take the other. There we go. Now this is all dark here. Don't worry about that. That's not really there. That's all what we call anisotropy, which we'll talk about in a second. So there's your biceps tendon, humeral head, supraspinatus, deltoid, bit of subcutaneous fat here, and then the skin. Okay, so that is, if I go to here, so there now I'm optimized for the supraspinatus, which is here, and I've got my biceps tendon as a landmark here. Now, here I've got the focus, so I'm at the same level, which gives it the best image quality. And now the depth I've got probably optimized, probably go a little bit one more maybe. So you want to use as much real estate of the screen as you can, and therefore you can see as much as you can. Okay. Now, the anatomy here, if I just freeze it here, what you've got here is this is the greater tuberosity. So this is the superior facet, and then this is the middle facet. So here actually is only where you're going to visualize the supraspinatus. And this is actually infraspinatus. So it's not all, this is not all supraspinatus, it's just literally here. Now, they do converge a little bit. So the supraspinatus will envelope over here a little bit, and the infraspinatus vice versa. So this is actually a mixture of the two. But this is the break, if you like, from the superior facet to the middle facet, supra and infra. So if I unfreeze that, so therefore, when I find that position, I can bring this into the center, and then I can scan all the way through. I'm constantly adjusting my position to keep that supraspinatus at its brightest. So you can see I'm constantly angling the probe to make that as bright as I can, right down to the insertion here. Okay, and then back. Now, from this point, I can go longitudinal, okay, and therefore I've got the supraspinatus in long section. So if I just freeze that, so this is now supraspinatus. This is the superior facet. This is the deltoid, and obviously subcutaneous fat and skin at the top there. Okay. Now, as I say, these tendons blend into one another, so it's quite difficult to spot where they merge. But if you keep going, if you keep scanning out laterally, eventually you'll see that slope, sort of slope off, and that means you've gone over the facet, and now you're on the infraspinatus. So that is actually infraspinatus, and then back onto the supraspinatus. So you can see you can't actually differentiate them very well. Okay. So what you can do, if you lose yourself, if you go fully medially, you'll see this tendon here. I'll freeze that. This is actually the biceps tendon, okay, at its most medial aspect. And that, if you lose yourself, you can go as medially as you can with the probe here. And then as you come back out laterally, the first thing you'll hit is the supraspinatus. And that's a good way of finding your supraspinatus. Now, don't forget that these tendons are quite broad. The beam that's coming out of this probe is only 1 millimeter thick. So you're effectively seeing on the screen a 1 millimeter slice of this tendon. So in order to visualize the whole tendon, you need to scan all the way through. There's the biceps tendon again, all the way through. And I'm through into infra now as well. Okay, so just don't forget to scan all the way through the tendon, but that's also in transverse as well. So constantly, you'll find you're constantly going to have to adjust as well your probe angle, so to keep the tendon bright. Your main objective is to keep the tendon bright, because when it goes dark, that means it could be tendinopathy or even a tear. Okay, so what are the types of tears you can get? Okay, so you can get a partial thickness tear, and you can get, I'm going to freeze this, Abid, so you can have the rest of your arm, is that right?
Okay.
Yeah. So you can get a partial thickness tear, you can get a full thickness tear, or obviously a complete rupture. So if you look at the screen here, a partial thickness tear will essentially mean that it's partially going through the tendon, not all the way through. So it could be like a dark defect through here. So we might be looking at a small partial thickness tear through here. Okay, my glasses are steaming up here. I'll just give them a, okay. And the full thickness tear means that effectively the tear goes through the whole thickness of that tendon. And that's different to a complete rupture. A complete rupture goes through the whole thickness of the tendon, but also the whole width of the tendon. So it's a complete rupture would be a full width, full thickness tear. If it's just from the articular surface to the bursal surface, that's just a full thickness tear. And then if I go back to a long section, oh, and there you can see what I've done is I've put the probe the other way around. So you see how it's flipped the image? So the biceps tendon is now on the left. So that doesn't work for me because when I move the probe one way, the tendon goes the other way. So I need to correct that. Okay, so now the biceps on this right side, and if you look at the screen, it's on the right side here. So I know that's correct. And the way you can tell that is this little S at the top here. That's where your probe marker is, and that's your orientation. Okay, so, oh yeah, I was going to go into, if you want to describe your thickness, now, so this would be articular surface. This over here would be the bursal surface. So if you get a tear that's basically just on this side just here, that would be a bursal surface tear, okay? And if it's on this side, it would be an articular surface tear. Now I think the articular surface stops around here, so all this would be insertion. So if it was anywhere here, I'd call it an insertional tear. Okay. Now this is called the bursal surface because obviously that's where the bursa lies. It lies all the way around the shoulder. If you look at this image, this is where the bursa would be. And sometimes that becomes thickened, or it can become filled with fluid. And that would be a bursopathy.
Just to lock it for me, please.
Oh, sorry. Are we back there now?
Sorry, guys, I just lost the.
There we go.
There, we're back. Thank you.
So yeah, so if you look at Abid's here, he's got a little bit. Where's my deck? There it is. It's got a little bit of thickening to the bursal surface. So now what I'm doing here is I'm optimizing my image to look at this bursal surface here. Okay, this isn't optimized. Okay, this is all dark and it doesn't look right. So I'm not worried about that at the moment. I'm interrogating this. So this is what you have to do. You have to optimize the image to the area that you're looking at. So I've got my focus here, and I've optimized it to look at this bursal surface, and that's a little bit of fluid in here, a little bit thickened. Now you can get people that will have sort of naturally thickened bursa, and they may not be symptomatic. You know, if you've got someone who does a lot of swimming, they may have a naturally thickened bursa that's not really very symptomatic. And that's one of the things with ultrasound, is to not get too keyed up with the pathology as such. Think about your patient, and it's, you know, treat your patient, not the scan. So if you just be aware that you might see lots of things in ultrasound that may not be the things that you're actually interested in finding out as the cause. Right. So there are other things that you can change to help you differentiate tears. On here, it's the chroma maps, and if you look at your screen, you can see the color changing. Okay. Now sometimes your eye is better attuned to this sort of color, and you can pick out a lot of tears just simply by changing the color map. And that's something you just have to play around with it and get used to. But it's quite good if you're unsure of looking at the one screen like this all the time, to just change the color map, and it might just highlight some other things for you. I think Abid mentioned last week also that a light pressure is always good in ultrasound. So keep your pressure light, don't press too hard, and then that will allow you to see things that you'd probably be otherwise compressing, just like the bursa, for instance. You can get things like calcification within the tendon, and that will just appear as basically a white blob. It may have some shadowing behind it. It may not, depending on what sort of stage it's at, and those can be quite symptomatic as well. Frozen shoulder. You don't really. Frozen shoulder's a bit of a clinical assessment, but there are some sort of indirect signs that you can look out for. To be honest, I very rarely pick them up for frozen shoulder, but they are there sometimes, and that's can be a thickened Coraco humeral ligament, which runs across here. Oops, I just...
Sorry, I'll just get a better angle for you. I'm getting writer's cramp holding this stick now.
Yeah, sorry, but you're okay.
It's all right.
So this along here is the Coraco humeral ligament. So if it looks thickened, and sometimes you can get some fluid around here, that can be indicative of a bit of a frozen shoulder, and also the rotator interval, which is a bit higher up. Probably best to see the rotator interval from up here, just where it dives into the sort of intra-articular portion here, which you can put the colour Doppler on. And I must admit I've not seen it too often, but literature suggests that it can be an indirect sign, so it's something to look out for. That's the biceps tendon again, as I said, which we can cover. We're going to cover in a couple of weeks, I think.
Yeah.
Right. I think I've covered most things there. We'll have a look at the infraspinatus now. It's a slightly different position. So, Abid, with your left hand, if you can pop that across onto the other side, and this has the effect of stretching out the tendon. My glasses keep stinging up. I can't see the screen. There we go. So what I tend to do is I tend to come back into the muscle belly. I can take the focus down, probably increase the gain a little bit. And this, let me just freeze that. This here is the sort of central tendon of the infraspinatus, which I'm going to follow around on to its insertion. Okay, and this thing that we talked about before about anisotropy, this dark area here, so you want to rule out that is a tear or tendinopathy, and the way to do that is you just heel toe.
Sorry, I was going to try and get a better image for the viewers there.
Okay, so coming round, and I'm just angling in now. See how I'll freeze that. See how this now is all bright. So I'm pretty confident that Abid's infraspinatus is looking nice and healthy there. Okay. Now, obviously, I'll just go over, because this is in the area of the infraspinatus, is the glenohumeral joint, which is at the back here. Now, for that, it's a little bit deeper. And I'm just going to and take the frequency down a little bit, because I'm going a little bit deeper. Maybe increase the depth. Oops, wrong way. And then I can go down into here. So I've got the glenoid here and the labrum here. There. Labrum, back of the joint here, so you look for any effusion here. And teres minor will be down here. We don't see much injury in teres minor, but that would be a little bit lower, which is here. There. One thing to be aware of, if you do have a like a full rupture, you'll get superior migration of the humeral head, and that has the effect of bringing teres minor up as well. And so you can confuse that with infraspinatus, and you think, oh yeah, infra's intact, but it's actually just because the teres minor has just come up, and it's been in your view. So that's one thing to look out for. Okay. You got any questions coming through, Steve?
Not as yet. No. You're obviously covering everything very thoroughly.
So another thing to be wary of is obviously the deltoid muscle, because I don't know whether you can see here, when you get like composite of the fascial planes of the deltoid muscle, it can cast a shadow down and through. Okay, so just bear in mind that that's not tendinopathy of your tendon. It's the fact that this is coming through and casting a shadow through that. Okay, now I tend to scan the shoulder standing behind the patient. Okay, you can scan anteriorly, and usually sometimes when you're first starting out, it's quite nice to scan anteriorly. I don't know whether I can turn you around now, just to show that. So if you bring your legs around this way, okay. So you can let's check the depth down. So you can scan anteriorly. The only problem with doing this is, let's get that right around, is that this will tend to give you a little bit of repetitive strain injury. So if you're doing a lot of scanning all day, this is probably not the best position to get yourself into, because you've got to hold your hand at a certain level, especially if you're sitting down, your hands high up. So that's why I tend to scan from behind the patient. You can get, it can be a little hard to interpret the image that way, but if you do get used to it. So I'd recommend that if anyone's with your practice. Just trying to think, I've pretty much covered most things to do with the supraspinatus and infraspinatus.
I'll just put now there. If they can all hear me, is there anything you want Adrian to go over? Anybody, just drop me a message here, or anything that.
Yeah, related to anything really, scanning or
any requests. Adrian takes requests.
Should we just go through the different what's the word I'm looking for? Probe orientations for the different bits of the tendon.
Yeah.
I'm not sure they got that
through
with my camera skills. I'll try and get a good image so everyone can see exactly where your probe's going.
So you mean see it like longitudinal? Really?
Yes, yeah, long trans and any techniques you might think would be more useful for.
Yeah, I mean,
Adrian.
Yes.
Sorry, if you can start that. Yeah, I mean, if you could do that would be great. But just had a question come in, so as I've asked, I wonder if I can put it straight to you. Can you demonstrate? Oh, it's gone. It's scrolled. Can you demonstrate a dynamic assessment? For example, a patient abducting the arm. Yeah.
So if you've got like someone with a thickened bursal, which actually I did have, didn't he? What I tend to do is come and find the acromion here, okay, and then just off the acromion you'll see. Let me just annotate this for you. Oh, it's gone. So that's the acromion process. This is the supraspinatus. This is the bursa, okay? And we're looking through here. So this bursa has got to fit underneath here. So this is all bone. And don't forget, this bone carries on. This is just what I'm seeing with my ultrasound, but the bone actually probably carries on to here and then carries on under there. So this space is very, very narrow, especially when you've got a thickened bursa, and that's the tendon. So if I take that off now, you'll see as I raise his arm up and it rotates underneath, okay? And you can see it's going under there. quite nicely. You're not feeling any symptoms there, Abid?
No.
Yeah, so you can see he's got quite a thickened bursal, but it's going underneath, and it's not impinging. So what you tend to see with that is basically bunching. It'll bunch up here, it'll bulge here. You might even get a little bit of fluid bulging up as well. And then the patient will tell you that that hurts, and that's your impingement sign. There is another impingement sign at the coracoid. Let me just, I know just these glasses keep sticking up. So there's the coracoid, and then what you do is you externally rotate, and you can see that moving there on the screen. Or you'll get basically here you'll get like a bunching and some fluid up here, and that's basically called that like an anterior impingement.
Couple more questions coming in.
Yeah.
You're going to cover one of them as you go along. So could you go over the differentiation of each tendon, please?
Yeah.
That's one question. While you're doing that, another good question's come in. What are the common mistakes when scanning? So maybe when you're showing the differentiation, could you, maybe if there's too much pressure on the probe, what difference does that make?
Yeah. So two great questions. So this, to differentiate the tendons, as I say, it's quite difficult because they do merge. So as I say, you need to find that landmark there, which is your superior facet and your middle facet, and you know, okay, so infra is going to be here. There's going to be a bit of supra coming over and a bit of infra coming over, but that's essentially how you differentiate them. Now, without being too rude to Abid, if you get a real slim patient, sorry Abid, you'll see the differentiation quite nicely. And what you can do is, it's probably a bit difficult on this, but when I move the probe, just get back, just slightly out there. Let me get back there. So when you move the probe backwards and forwards, you see. Let me get the pointer. You see this bright bit here. If I move backwards and forwards, that's going that way when I move backwards and forwards. So I know that's coming from over there. Okay, and this one, if I move backwards and forwards, it's coming from over that way. So I know that you can differentiate that way. If you see the fibers well enough, you can differentiate it like that. And the other question about pressure. So let's. It's quite difficult to do it from this one because you haven't got any fluid. We have there. There's a bit of fluid there. So if I press, I don't know whether if you look here, there's a little bit of fluid. If I press, you see that's gone, and it comes back. Press, and it so you can, just by pressing too hard, you can basically say, oh, that's fine. There's no fluid there. But if I release the pressure, the fluid comes. Okay, so it's got a little bit of fluid here, and actually you can see the bursal margin here quite nicely, and that's all there with the fluid. Yeah. So any others? Don't forget your constantly tilting the probe to rule out anisotropy on the insertions there. If you've got any tears, obviously measure them. If it's a bit of a chronic tear, what the surgeons will probably want to know is, is there any sort of muscle atrophy, any fatty infiltration to the muscle, which you can have a look at the back. And if there is, if you look at these two here, they're pretty dark. If the supra was really bright, then you could say, oh, there's a little bit of fatty atrophy in there, and that might be an indication that, you know, surgery might not go as well. So that's one thing to look at, just to tell them how fatty infiltrated the muscle is. And you'll probably notice a bit of atrophy. There'll be a little bit of indentation into the back here, where the supraspinatus muscle is. Yeah, did you get the differentiations of the levels here well enough? So you've got the skin. This is the subcutaneous fat here, then the muscle, and then down into the bursa and the tendon, and then the bone. So it's really good to get these delineations. So if you go on the muscle, you'll see the fibers moving backwards and forwards, whereas you won't see that on the muscle. Okay, the septi remain pretty still, but you can see the fiber differentiation here through the muscle. And if you go into long section, you'll see that in the tendon as well. Okay, obviously look out for cortical irregularity, because obviously I'm not sure what the exact figures are, but I think it's if you've got cortical irregularity, I think the probability of a tear is in the sort of 70%. If you've got fluid in the biceps tendon and also fluid in the bursa, then I think the figure goes up into the 90s. So they're all subtle things you can look for that can help you think, oh, I'm suspicious, I should be finding a tear or something like that.
Do you use the Doppler much when looking at the shoulder?
I don't, but only if they're querying frozen shoulder. As I say, you can put the Doppler around the rotator interval, around the biceps tendon, and if there's any Doppler around there, that can be a soft sign, if you like, for frozen shoulder. You can put it on the tendon to see if there's any sort of active sort of tendinosis within the tendon. I don't see that often, to be honest. Biceps tendinosis, you'll see some Doppler around the biceps. I'm going to go over the biceps in a couple of weeks anyway. Long head and the distal attachment. But lumps and bumps, you might pick up the odd lump and bump in the shoulder, and it's always use Doppler for that. That's a definite must.
Why, Adrian? You want to just clarify?
Yeah, so if there's any Doppler or colour flow within the lump or bump, is obviously it's got some sort of blood supply, so they'll want to interrogate that a bit further. Ultrasounds can be good for lumps and bumps, but you should use it with caution. Always correlate it with either other imaging, because I've seen you can see lots of stuff that look benign but be not benign and stuff, and vice versa. So the crossover is quite big. So just be aware of lumps and bumps, certainly. The other way you might use it, not necessarily for the shoulder, but it's just like synovitis around joints, things like that. You need to be fully versed with your Doppler settings though, because that is key. Make sure you take your Doppler settings right down to pick up the low flow. If you've got it set too high, you won't pick up anything, and you might just have a false negative there. Any other questions there?
Nothing else come in since, and I had a couple of people come back and said thank you for covering what they asked for, so that's great.
Stuff. One thing actually I should have said with the infraspinatus, if you pop back, sorry Abby, you're getting tired there.
No problem.
Giving your shoulder a workout.
Anything for the audience.
So dislocation. So if you've got a dislocation, anterior dislocation, you can sometimes get like a Hill-Sachs lesion, where the humerus bangs onto the coracoid here. and that can be found here, just at the back here, just underneath the infraspinatus tendon there, and basically, so this is your tuberosity here. So basically, and this is your infraspinatus. You basically would see like an irregular defect here, almost like it's been punched out. And that's your Hill-Sachs lesions. And that's always worth just mentioning if you see that. The Bursal Surface. Little bits of osteoarthritis. Look for lipping in the bone. You can even pick up fractures. And that basically what you're looking for in a fracture is just basically like a step in the cortex, and it'd be like a sharp edge, and you may get a bit of edema around that as well. And you can pick up fractures on ultrasound, certainly, that not necessarily being picked up on X-ray. So that's one to look out for. Obviously, we're going over the biceps tendon in a couple of weeks. This is quite a just by this anterior free edge here. So if I take this right over to get the thing right here. No, it was right the first time. If you go. So there's the biceps tendon. So if I come back onto the supraspinatus, it's quite a common place just by this anterior free edge area here to get tears.
So just put your cursor there so they can see where. Just around here as I go. There's the biceps tendon come out laterally, and there's a change into the infra, and this is quite a common area here, just to get little defects there, and you just have to manipulate your transducer to make sure you cover all those areas, and you do that just by heel toeing the probe. Technique.
Yeah. So just heel toeing the probe like that, just to angle to get, because if your beam isn't at 90 degrees to the area that you're looking at, then you're potentially going to have some anisotropy. Just trying to think if I've covered everything.
Trying to just maybe do a recap for them, scanning the tendons in long and then short axis or something.
Yeah.
Just from start to finish for them.
Yeah. So what I do, so I come up onto the ACJ. Okay. Obviously, I'd have your arm behind the back. Come down onto the supra. Okay. Now, biceps is down here. So angle it here. You've got supraspinatus here, bursal component, and this is the tuberosity here. And
is this a transverse image?
So this is transverse.
Yeah.
Okay. So you think about the actual tendon is coming at you, if you like. So rather than a long section, it's a transverse section, so it's going to cut through there.
So cross section, essentially. Then.
Yeah. So cross section.
Yeah.
And again, knowing where your landmarks are for your anterior and middle facet, you can see just the difference here, where the contour change.
And can you show them how it changes when you go into a long axis from that short axis, and then how you keep the tendon in the picture, perhaps?
Yeah. So what you do is if you're seeing the tendon nicely, you want to see a nice bony echogenicity there, brightness to the bone, and then you can do it in one sweep, but you'll see that it's probably better to just hold the probe, so when you turn, you're turning right on the same axis and you're not moving because it's quite easy to move, especially when you've got jelly on the patient there. And then that's the long section where you're going to be seeing your tendon fibula pattern there. Okay.
Very nice.
And then if I angle up, do you see how that goes dark here? That's not tendinopathy. That's just my beams. See, these fibers are going down this way. The beam's coming straight down. So I need to angle so the beam hits those fibers at 90 degrees, and then they'll all fill in and look nice. Okay. And then again, hold the probe and turn transverse, and then you're back on your transverse section. Okay.
And do you want to maybe put the calipers on it while you're there, actually? And, have we measured anything yet?
No, I mean,
our calipers
I don't tend to measure. I tend to eyeball it, and if I think it's thickened, I mean, let me go. Hold on a second. Where's my measure? There it is. I mean, you could potentially measure it, but you know, you're going to measure in different places the next time. So,
would you have to compare the left shoulder scan with
exactly.
the right shoulder scan to see?
Yeah, exactly. If I thought it was a bit thickened, a bit tendinopathic, then I'd go over to the other shoulder. And you could probably do it on this screen. You can dual the screen.
What's the average diameter? About 3 to 4 millimeters. Is most tendons in the body, I think, are.
Yeah, but as I say, I tend to eyeball it and just compare it with the other side. And if it's different from the other side, then it's, you know, I'm on the same side here, by the way, but I'm just showing you example.
Would you recommend the audience that are starting scanning measure them first, or do you think it's good enough to eyeball it? Can you see pathology clearly if you're measuring? Do other sonographers?
You could. The trouble is, everyone's going to have different, you know, different tendon thicknesses, I would think. So I would probably. Yeah, I mean, you could measure it and compare and measure
compare
the
with
other
the other side.
Yeah.
Yeah.
Just make sure that when you do that, you get it in the same plane. So let me go back. So if you're measuring one place, make sure you're measuring it in the same place. So get to a level where you want to measure. Let's just say it's there, and then just make sure you get the same image on the other side. Now you can see that I can't see the biceps tendon. I've just realised that Abid's in the cras position. So if I move him back into the modified cras, I now have the biceps tendon, which is here. So that's the landmark. So that's just changing that position. I could see that, but I couldn't see it before.
Yeah.
Okay. And then this is the tendon, and this is your free edge here. There's a common place to get tendon tears. Yeah. You're familiar with the partial thickness. So partial thickness just partially through the tendon. Full thickness through the full thickness of the tendon. Rupture is full width and full thickness. So complete tear. And what you'll get with that is what we call the naked tuberosity sign, which basically means that this deltoid muscle here will just come down and meet this, and it'll just look like a naked tuberosity sign. So you won't have a tendon here. Okay. You may have some bursal thickening, and you may have the bursa that's quite echogenic. So it's a good idea just to make sure that you're not looking at a really thickened echogenic bursa. Because obviously that can mimic a tendon, and you can do that just by moving, dynamically moving, and just seeing it and squashing and things like that. So always use your machine to its best advantage. Manipulate your controls, alter your focus, alter your depth. Always keep manipulating your machine to get the best image. Just to mention the gain as well, I didn't go over the gain. So if I'm going to turn the gain right up, and you can see that is very bright now, and I'm going to see very little. So always alter your gain. Your gain's not adding any more ultrasound dose into the patient. It's just simply emphasising the returning echoes. So don't be afraid to change your gain. Get it to what you like, so you can see the borders and things, and just manipulate your gain and things like that.
Brilliant. That's great.
Okay.
Thank you. Really, really thorough. Thank you ever so much.